big topic here. And now, three of our own stalwarts here, starting with Roxana. Roxana rocks. I always say that. So, Roxana has another contentious topic, long-term antiplatelet, antithrombotic therapies in stable coronary artery disease. We are asking stable coronary specifically. Roxana.
Hello. If you could do that for me, thank you. So it's okay.
Mia culpa.
Hello, it's hard to follow such a rock star. Thank you. Thank you all for having me here to talk to you about long-term antithrombotic, antiplatelet regimens. I did stable, but also after a myocardial infarction and ACS, the patient stabilized. So we need to take that into consideration because a patient who's had a history of a prior MI and a prior PCI will have obviously stabilized and will need most likely more potent agents rather than less. Important for you to note my disclosure specifically to the academic research organization that I lead at Mount Sinai. We've built a full-service academic research organization with clinical trials and, of course, research payments to the institution. So why are they needed? I think it's important to note that we have now found that, for sure, antiplatelet therapies are the cornerstone for so much of what we do. And we just heard all these other therapies that are becoming available, namely LDL reducing therapies, lipid lowering, and then, of course, the diabetes drugs that also have very, very important implications in patients with coronary disease and post-PCI. But certainly, antiplatelet therapy comes first and foremost for both primary as well as secondary, but most importantly in our patients undergoing PCI. Most of them leave the cath lab with a stent. Most of them will require dual antiplatelet therapies for some duration. And then, of course, the idea of what we do over time with these patients is what we need to really, really think about, because those same patients who undergo PCI, who present with an acute coronary syndrome, who have stable CAD, will have some long-term recurrent vascular events that we want to prevent. How do we do this? How do we navigate this? Certainly after PCI, there are a tremendous number of places where we are very, very much focused on. Aspirin, using the thromboxane A2, and last year I spoke about retiring aspirin, and we'll talk a little bit more about that because we're learning more and more that maybe we are overdoing the aspirin, and I'm really, really thinking more and more about how we could replace aspirin with some of the better, more efficacious drugs, such as those with ADP antagonists like clopidogrel, prasugrel, ticagrelor, and even cangrelor. And we'll talk a little bit about the drugs that are now coming in, some of the very interesting newer factor 11 inhibition that is now on the horizon. So we're not going away from anticoagulation and antiplatelet regimens, and I think it's important to think about that. But where we've been in the whole duration of antiplatelet therapy in stable patients or in any patient after a percutaneous coronary intervention has been sort of a roller coaster. We started worrying about thrombosis early on when we had drug-eluting stents of first generation, when there was a late thrombosis event that was associated with first-generation drug-eluting stents. And at the same time, we were developing, enhancing those first-generation drug-eluting stents, but also having potent agents. So we began seeing a reduction of those ischemic events, higher bleeding when you push the envelope with those more potent agents, and where we ended up is bleeding became very, very much center. And we began to realize that bleeding awareness the very important association of bleeding and mortality was one that we couldn't say it's a causal issue, but certainly an association where we saw those who bled more died more often, and we needed to kind of rethink this and reboot this. And I'm going to say that I was very responsible for that bleeding awareness time. We probably published hundreds of papers talking about bleeding as an important predictor of risk for our patients. And I think where we are now with the safer stent platforms, more imaging, more nuanced understanding of dual antiplatelet therapies and what happens when you stop, we're in an area of equipoise where we could get novel, where we can use machine learning and artificial intelligence in figuring out who gets what, in whom, for how long, which drug, and in what cases. And I think some of those approaches with shorter durations and withdrawal of aspirin are some of the things that where we are really very much focusing on. So I think the hot topics are here for all of our patients in terms of antithrombotic therapies, and I'm going to cover those in the next 20 minutes or so. So I'll start with my favorite topic, aspirin-free strategies, and certainly the fact that we absolutely should tip our hat to aspirin at a time when we had nothing else on the baseline therapies. It absolutely helped us. It reduced vascular events. Fatal, ischemic, and non-fatal events were reduced. If you treated 10,000 patients for aspirin for a year, you reduced 100 to 200 of those events, and the price wasn't so bad. It was major extracranial bleeding of about 10 to 20 events and one hemorrhagic stroke. That math works. That calculus works. But I think where we are today is very different place. The risk reduction strategies, we just heard a slew of therapies that we heard presented where heart failure hospitalizations are coming down, but there are so many other things with SGLT2 inhibitors, with lipid-lowering drugs, and other therapeutic regimens that are available for our patients, where that risk profile for that patient is very, very different. We also have novel antithrombotic regimens over the last decades or so, a couple of decades, where we have made a huge impact in reducing those ischemic events. And what we're seeing, that combination of those novel therapies with aspirin is only increasing the risk of bleeding. And certainly we know that the bleeding risk, especially the direct gastrotoxicity of aspirin to the gastric mucosa, is one that we absolutely know and are completely aware. How many of you have seen GI bleeds in patients who had aspirin and a potent P2Y12 inhibitor? And it is often that we need to imagine that even the enteric coating that we are worried, that we believe were protected, doesn't really change the GI erosions and ulcers, and that in fact there is a very important impaired drug absorption leading to reduced platelet inhibition when the aspirin is coated. And it wasn't just a magic thing that I thought about that, well, we should withdraw aspirin with ticagrelor or even prasugrel. These things were done in laboratories with early studies. This is Paul Armstrong. We have many, many other studies with ticagrelor. This one is with prasugrel, where you see a little additional platelet inhibition following stimuli with several agonists in presence of a potent P2Y12 inhibitor. Aspirin is doing not much more than what the potent P2Y12 inhibitor is doing, whether this one is prasugrel, but certainly with ticagrelor. And remember, this is a good receptor to inhibit. The P2Y12 receptor plays a central role in platelet activation and amplification, and we already have seen its established efficacy of P2Y12 inhibitors in reducing stent thrombosis. Stent thrombosis went away as soon as we used P2Y12 inhibitors, even in those early days. And certainly, there's no question that this particular receptor has a major role with other signaling pathways, including the final common pathway, which is the GP2B3A receptor. And of course, we have seen several randomized clinical trials now thinking, well, can we take aspirin off? And of course, I'm very proud that we ran here at Mount Sinai the Twilight trial, but there were others who did same before even as we started. The Twilight trial was presented in 2019, but global leaders in 2018 randomized 16,000 patients to ticagrelor monotherapy after a month of aspirin plus ticagrelor in all comers. And they showed a numeric reduction, but they were too aggressive in looking and too hopeful to show a superiority in ischemic events. And so they failed there. And their comparators, unfortunately, was difficult to do. But they looked for death and Q-wave MI. And in fact, if you look numerically, it's lower. They just they did not meet the superiority endpoint. But our Japanese and Korean investigators in Asia did show clopidogrel monotherapy after short duration of DAPT to be associated with less bleeding and no further ischemic events. And then the Tycho investigators came after the Twilight trial with 3,000 patients, showing that the potent agent ticagrelor, after 3 months in acute coronary syndromes that included STEMI and non-STEMI, was associated with less bleeding and no further increase in ischemic events. Their endpoint had both bleeding and ischemic events, so they showed superiority, but you really have to look. The devil is always in the details, because the Twilight trial was the only prospective randomized double-blind placebo-controlled trial of aspirin withdrawal that was conducted, sponsored by the Icahn School of Medicine here at Mount Sinai in our academic research organization, with 187 sites in 11 countries, where we had an open enrollment period of 3 months of patients in whom the clinician wanted to put the patient on an aspirin and ticagrelor. They all left, and after 3 months, we counted their pills, we made sure they didn't have major ischemic or bleeding events, and we randomized them to aspirin plus ticagrelor, continuing that onward, or aspirin plus a matching placebo. We felt that it was very important that no one knew where that patient belonged, whether they had aspirin or not, because aspirin is so widely available. And boy, does Bayer do a great job in advertising how great aspirin is. And we felt that it was important that nobody knows what the patient receives. And after a year, with the very, very close period of watching these patients, our hypothesis was that we would reduce bleeding. Oh, well, you better, right? You're withdrawing aspirin, you should reduce bleeding. But we also needed 7,000 plus patients to have the very good confidence that we were not exposing patients to ischemic risk by withdrawing aspirin. It really was a very important question. Nobody believed us. It seems like, oh, well, that's an easy study. But believe you me, when Dr. Sharma suggested this, that we should do this, we were like, who's going to enroll in this patient? Withdrawing aspirin when you think they need a potent agent? And sure enough, we were able to convince, and then we showed, without a doubt, in the ITT cohort, that boy, did we reduce bleeding by an order of 44%. Numbers needed to treat 33, BARC 2, 3, and 5, and we reduced BARC 3 and 5 bleeds by 55% reduction. So this was really important. If you leave these patients on, you're going to have a 7.1% bleeding rate over a year period. And what was most important, and I think this was the jackpot in a per protocol that became our safety analysis to make sure that we didn't have higher rates of death, MI, or CVA. These curves hugged each other for the entire time of the experiment with absolutely no difference. This was really, I think, the home run that brought us to the New England Journal of Medicine with this double-blind placebo-controlled trial. But what about that patient at a high bleeding risk? What do we do with those patients? Because in twilight, not, you're going to be put on ticagrelor. They're not really very high bleeding risk, and you had to go through that period of open enrollment where there was no bleeding. So what about the patient that you're very concerned about? Multitudes of risk factors with high bleeding risk. Well, this study, for the first time by Marco Valgimigli, randomized 4,600 patients to an abbreviated DAPT versus a standard duration of 2 to 6 months, even though the guidelines are telling us about 6 months for high bleeding risk patients, 3 months or so. And what we showed that in high bleeding risk patients, less is more. Stop the dual antiplatelet therapy after a month, and you have to meet those criteria of high bleeding risk. Elderly, frail woman, prior stroke, prior bleeding, anemia. These are the kinds of things that you could define, and we've defined high bleeding risk patients. And you see here, no change in ischemic events by stopping the dual antiplatelet therapy, going to a single therapy, whether it's aspirin or clopidogrel monotherapy, you will reduce bleeding. And we were then able to, with the work of Marco Valgimigli, myself, George Dangus, we were able to bring all of these trials together with a very first and largest individual patient data analysis of P2Y12 monotherapy after a short duration of DAPT. And we showed exactly that. No difference in ischemic endpoints of death, MI, stroke when you go to a short period of dual antiplatelet therapy and then changing to a P2Y12 monotherapy, and you will reduce bleeding. It seems like that's the way we should go almost in everyone, but the guidelines said otherwise. They gave us a 2A recommendation for P2Y12 monotherapy. But there are many, many more trials that are now ongoing. The Legacy trial with ACS patients and the NEO Mindset, they want to stop the Antiplatelet, they want to stop aspirin immediately. So we're going to find out in the next couple of years about that. What about de-escalation? What does that even mean, de-escalation? Well, de-escalation is if you could take a potent agent, either give it at a lower dose or change it to a less potent agent. And this is in acute coronary syndromes, but it's something to think about even in chronic coronary syndromes. In chronic coronary syndromes, we don't have these de-escalations, but it's important for you to think about this, the guided de-escalation of using platelet function testing to make sure that we could calm down, and we can use these guided de-escalation trials for chronic coronary syndromes, especially when you have a complex PCI. And here in this cath lab, we certainly have many of our chronic coronary syndrome patients with complex PCI who receive a potent agent. For how long should they receive a potent agent? Here, these investigators took these patients, randomized them to receive prasugrel, but in the guided group, they stopped the prasugrel, went to clopidogrel, and everyone received the platelet function testing. And if you were not responding to clopidogrel, only then you were elevated back to the prasugrel. And what they showed is actually numerically better. Their non-inferiority was there, but they were looking for superiority and just missed it. These are very difficult studies to do. But to me, this makes a great deal of sense. Use some guidance. Think about perhaps some of your patients and de-escalate when you can, even in chronic coronary syndromes. It's a 2B recommendation in the European guidelines, and certainly there are also genetic testings that can also be done. This is in STEMI patients, but you can even think about this in the setting of chronic coronary syndromes where you can think about looking at those carriers of the CYP2C19 star allele 2 or 3 for the patients where you want to give them clopidogrel monotherapy. Maybe some guidance using that in a guided de-escalation can work. And in fact, what they showed in popular genetics is that this can have an important impact in reducing certainly the overall bleeding rates and having a non-inferior outcome in terms of death, MI, stroke, or major bleeding. Remember, none of these are very well powered for ischemic endpoints alone. You see how they're putting bleeding and ischemic endpoints into the primary outcome. And when guidelines look at these, they just, they frown upon it because you cannot get a class 1 indication for anything in that way. There's also a very interesting analysis in patients where you could de-escalate from the dosing of prasugrel 10 milligrams down to 5 milligrams in East Asian patients, and you're seeing there that you could reduce bleeding events without changing ischemic events. And in fact, down the line, a month after an MI, in a stable patient going from aspirin ticagrelor to aspirin plus clopidogrel was evaluated in Talos MI. And here you can see that these patients, 3,000 patients randomized, they were able to show that you could do this unguided and de-escalate in all-comer patients after a month. If they're stable, you can go to an aspirin plus clopidogrel and de-escalate from that ticagrelor and reduce bleeding without increasing ischemic events. Now, they again showed a composite of death, MI, stroke, and bleeding in favor, but this is all driven by reducing bleeding and no change in ischemic events, similar to what we have seen in the past. So if you put it all together in terms of de-escalating, for those of you clinicians who are thinking, well, when should I, like the potent agent for a long period of time, I'm worried about bleeding, but I also want to preserve this patient's protection against ischemic events, you may very well do this by de-escalating. And we do this all the time in the cath lab. It's so funny. I always think, how has Dr. Sharma practiced these things way before any of the clinical trials come out? But he's been doing this where he goes from 10 down to 5 of prasugrel, or reducing, going from ticagrelor to clopidogrel after a certain period. But what you see in this meta-analysis, you will reduce bleeding without increasing ischemic events. And in fact, you might even say that the point estimates for the ischemic events are in the right direction. So de-escalation is probably not a bad thing to do. And so what are you doing in this? This is a really, really nice paper that just came out. Which one, de-escalation or short duration of DAPT? And you can see pretty much either one is a good idea to preserve some of the ischemic benefit without increasing bleeding by either reducing the duration or de-escalating. And if you're not doing this in your practice, you absolutely should, especially in patients who are at high bleeding risk. Atrial fibrillation and PCI, now that is a conundrum. Anticoagulation is needed for stroke prevention in atrial fibrillation, and it doesn't work very well for protecting against stent thrombosis. Antiplatelet regimens, on the other hand, works great in protecting for stent thrombosis, but it's awful in protecting patients against stroke prevention in atrial fibrillation. Combine those two, and guess what you get? A bleeding disaster. We call it the triple therapy threat. But there have now been several clinical trials. I've been involved in 3 of those, but all of them showing that it is better for an atrial fibrillation patient to receive a novel oral anticoagulant, to also receive a clopidogrel rather than ticagrelor or prasugrel, but to go to a dual therapy with aspirin withdrawal almost as early as possible at the time of discharge for some of these. And in certain cases, you can go to 30 days, but never more than that. And in fact, if you look at that, and the reason for that is that if you do that with a novel oral anticoagulant and clopidogrel monotherapy, no aspirin, you will reduce TIMI major bleeding. That is exsanguination, guys. If you don't know what it means, the TIMI major bleed is 5 grams per deciliter, or a fatal bleeding event. That's what a TIMI major bleed is. It's pretty bad. Look at the point estimates in terms of protection for a novel oral anticoagulant and a P2Y12 monotherapy, and against intracranial hemorrhage. And of course, very important is that those major adverse cardiac events are pretty much hovering around the line of unity with no real signal of harm. Now, there are certain times where we have seen a little bit more stent thrombosis, but those are in those complex patients where maybe the patient is not responding to clopidogrel, maybe there was no imaging, maybe multiple stents were placed, and then they just stopped the aspirin and sent the patient home on clopidogrel that the patient was not responding to, and therefore there was this issue. But certainly we have to use a lot of our noggins to think about some of these things individually for our patients. And the North American consensus put this together. I was part of this with Dominic Angelillo and so many others, where the default strategy is less is more. Get rid of aspirin almost immediately after. In the peri-procedural period, you need aspirin, but go home on an oral anticoagulant and a P2Y12 inhibitor. But what I think is the best out of this is that nowhere for chronic therapy are you seeing aspirin. These patients received a PCI. In the guidelines, it says aspirin indefinitely, but not in AFib patients. Less is more for these patients. They will bleed, and aspirin will not be helping them. And if we can do a novel oral anticoagulant where we know there is some thrombin inhibition with those novel oral anticoagulants, especially the factor Xa inhibitors, maybe we can make even a little bit of a dent in terms of the antiplatelet effects of factor Xa inhibitors. And certainly you can see that there is an out for a patient who's at a low ischemic and thrombotic but high bleeding risk, where we're shortening even the dual therapy time and going to an oral anticoagulant alone much, much faster. And in those patients where I'm really worried about it, they just received 4 stents, bifurcation, I don't know if they used imaging, diabetic patient, lots of other risk factors. You might want to give that patient a month of aspirin along. I'm not so sure it's going to work. It's better to do imaging or to have a better physiology-guided PCI, but certainly you're seeing how this is working. What about native disease dual therapy? Now, here's an area where we have to think about the entire body of a patient who has atherosclerosis. We're so focused on the heart, a few millimeters of stents, how much literature is out there, but atherosclerosis is ubiquitous, polyvascular disease, and it is everywhere, in the heart, in the kidneys, in the legs, in the brain. And we need to be thinking about this Venn diagram of the patient who comes into the cath lab and receives a PCI, but also have peripheral vascular disease, cerebrovascular disease, and of course, very important high event rates for thromboembolic events everywhere, including limb events. And the synergy of the dual pathway is a very, very important one of the anticoagulant and the antiplatelet. I just told you that these novel oral anticoagulants do have some antiplatelet activity. And it's very interesting, the factor 2A and the 10A. And there is a very important synergistic effect with that P2Y12 inhibitors, where they target the 2 components of thrombosis, both coagulation and platelet activation. And so the COMPASS trial evaluated this in patients with stable cerebral vascular disease who had high risk. This was chronic patients, CAD and PAD, and they were randomized to aspirin monotherapy, rivaroxaban monotherapy at 5 milligrams, or Riva plus aspirin at 2.5 milligrams BID plus aspirin. This was a 27,000 patient study. It was stopped early, the DSMB, because of the extreme benefit that was being evaluated in that top arm of rivaroxaban 2.5 milligrams BID plus aspirin. And they stopped that, and you can see right here that the 3-year data of the best possible treatment was right here for the Riva 2.5 milligrams BID plus aspirin, 3 years cardiovascular death, MI, stroke, numbers needed to treat 77. There was less death, there was less stroke, there was no less MI, but certainly there were many, many less limb events, including 70% reduction in amputations. So if you look at this with the chronic and the COMPASS subgroups, you see that right here. MI was no different. Most of it was in ischemic stroke, cardiovascular death, and overall MACE really being driven by that important benefit that we were seeing. The bleeding outcomes were there, though. When you combine these two aspirin, and you wonder what might have happened if the DSMB didn't stop and the rivaroxaban arm, 5 milligrams BID alone, kept going. Because look at these two, there's not that much of a difference. But that obviously never happened, and because of that, the guidelines would only focus on this arm, the Riva 2.5 milligrams with aspirin, despite the fact that it was associated with more bleeding, and we're not really seeing this regimen being instituted in a lot of our patients, even though the net clinical benefit is in favor of giving these patients with chronic peripheral arterial disease and coronary disease a COMPASS strategy of reducing. Because if you treat 1,000 patients with CAD, if you gave those patients CAD and PAD, Riva plus aspirin, 13 MACE events would be prevented, and 2 fatal or critical organ bleeds would be caused over a mean period of 23 months. And when you see the fatal organ bleeds and critical organ bleeds, no clinician wants this in their armamentarium. And this has been one of the issues that we have seen. The other thing is very important is this direct oral anticoagulants in combination to antiplatelet therapy for secondary prevention, and we're seeing this. And this has not been alone. Like, you could see this in STEMI and non-STEMI patients, even those who stabilized after a STEMI and non-STEMI. We're seeing that there is much, much more bleeding when you combine this, and that is what the issue is. And even though there is a great benefit on the ischemic events, when it comes back to that, clinicians don't like that calculus. And the risk benefit is very, very important to imagine that. What about beyond 12 months? When do we stop these antiplatelet therapies? The maintenance strategy at the moment is aspirin for a lifetime. Well, our Korean investigators want to think otherwise. And this isn't new, you know, because we have data in the old days, 20 years ago, where clopidogrel and aspirin were evaluated head to head. But here is these event-free patients on DAPT, 6 to 18 months. The Korean investigators, 5,500 patients, said, why aspirin in everyone? We're going to randomize aspirin versus clopidogrel. Now imagine that in the Asian population, the CYP2C19 gene is much more prevalent. So they are very brave to imagine that they could have less ischemic events, certainly maybe less bleeding. I don't know what they were thinking, but they included all of these patients. They followed them, 37 centers in Korea. And this has been published in The Lancet, presented at ACC as a late-breaking trial. I think it was a blockbuster. It's showing that it's time for us to rethink aspirin indefinitely and for us to evaluate this in a much larger patient population. Why do I say that? Because their endpoint is like the kitchen sink, is what I call it. It has all-cause death, non-fatal MI, stroke, readmission to ACS, and major bleeding. All of those was in favor of clopidogrel monotherapy. Most of it, really, if you look at that, the numbers needed to treat are small to prevent one of these events. And it makes you think, what are we doing aspirin indefinitely in everyone? And we keep stacking therapies on top of each other. And it really was both bleeding and ischemic events were in favor of clopidogrel. You would imagine that, yes, clopidogrel is going to be better than aspirin. in reducing thrombotic events. But look at that, the bleeding events were also in favor of clopidogrel. And so it makes you imagine that this is something that we should be doing. We at Mount Sinai submitted a PCORI grant of over 20,000 patients in a pragmatic trial to evaluate this, and we're back at it at the NIH, and hopefully we could bring this all to you. So for chronic coronary syndromes, the choices and the strategy has been beautifully put out here in the Nature Reviews article by Davide Capodanno. First and foremost, evaluate the risk of that bleeding risk of the patient. And think about it like this. Is this a patient who's had a spontaneous bleeding event, a bleeding diathesis, an anemic patient, thrombocytopenia, severe liver disease, vascular intracranial vascular abnormality, neoplasia, extreme old age, frailty, and the use of oral anticoagulant? That's about 40% of the patients you see every day. But make sure you think about that. If the answer is yes, go to a single antiplatelet therapy. If it's not, then think about these other additional risk factors, especially peripheral arterial disease, multivessel disease, the burden of atherosclerosis, history of prior MI. And if the answer is yes, and there was a previous ischemic stroke, then you really have to be starting to thinking about that COMPASS strategy. And that is how you then imagine, and if the answer is no, then you start to go to the low-dose aspirin with ticagrelor, or maybe even like a Pegasus strategy that I didn't get a chance to tell you about. So imagine this, how personalized this is becoming. This is not the party of, oh, the guideline and one trial is going to tell me what to do with all of my patients. And so the guidelines for ACS and for stable coronary disease, and you see that here, is less is more, and we're getting more of an out with becoming novel with a monotherapy, P2Y12 monotherapy class 2A in certain patients after a DES. BMS is a non-starter. Nobody's using it anymore. It's only a month. But you can see here the idea of the monotherapy going faster, especially those patients at high bleeding risk. And then, of course, even in ACS, you have an out now with an earlier stopping of the dual antiplatelet therapies. So high bleeding risk, less. Always think about that. And I just want to end with this slide. We put this together at the European Heart Journal with Davide Cao, one of my wonderful research scholars who's now in Humanitas Hospital in Milan. And we felt like, yes, this is personalized approach, but let me make it simpler. I can just say that when you see your patients, put them in one of these buckets. Where does my patient belong? If your patient is in that right upper quadrant, high thrombotic, high bleeding risk, and believe you me, many of those patients that are at high bleeding risk have a high thrombotic risk, go with the shorter duration P2Y12 monotherapy and de-escalation. The other parts are quite easy. If they're at low bleeding risk, give them a long duration. Escalate, use low dose rivaroxaban. If they're at high bleeding risk, de-escalate. I mean, simple. I think I helped you out here a little bit. Taking home after, I wish I had an answer. Ischemic and bleeding risks have to be balanced. Early aspirin withdrawal is something to think about. It's a safe alternative. De-escalation is another way for you. It's a promising option. We need more evidence, but honestly, it's a good idea to think about that. Those patients on an oral anticoagulant, dual therapy you should not be giving DAPT to those patients, to none of them more than 4 weeks. And this dual pathway inhibition for chronic P2Y12 monotherapy can potentially offer more benefit, ischemic protection and bleeding protection for your patients, but we need to get a much larger scale study. I want to thank you for your attention.